Yeah. Thank you, Deepak, for setting the ball rolling. I think we have enough discussions about patellar instability. The case which I am presenting is slightly different. The problem is essentially a patellar instability, but how it is presenting to us is different. So that's an 18-year-old girl which comes, who walks with around 15 to 20 degrees of knee flexion. Apparently the foot is in neutral. Examined, the hip rotations are good. But what I see that the patella is actually gone out and it is actually facing outward and lateral. So these are examinations. We start to see that the patella is actually sitting on the lateral side. I try to reduce it, it just doesn't reduce. It's just sitting there. We flex the knee, the patella is sitting right on the side. So can I have a laser pointer? Is it working? Yeah, here. So the patella is actually sitting right on the, so the trochlear groove is empty and you start flexing. It's a fixed patella which is dislocated and out here, and the girl is around 18. So just an X-ray, that's a preoperative X-ray. The normal side, patella looks nicely sitting on the groove. The groove is here, but patella essentially is out of the groove, it is just sitting outside. You just can't see patella on the lateral view here. And that's a 3D reconstruction view. The patella just sitting out of the groove. So 18-year-old female presenting to you with the patella which is actually out. So we did hip anteversions and C4 tibial torsions. They were nearly normal. We did some TT-TG ratios, that's around 24 or so. The patient has amount of 4 degrees of valgus. And our audience question here actually comes as, how would you classify it into? Is it a habitual patellar dislocation? Would you actually call it as a recurrent patellar dislocation? Or is it actually classified as a congenital patellar dislocation? So that's 50-50? Yeah, so we need to actually see whether it is a habitual or essentially a congenital patellar dislocation, and I knew about it. I think if you look into the classification of a patellar dislocation between a habitual patellar dislocation and a congenital patellar dislocation, the habitual essentially dislocates and relocates spontaneously with flexion and extension of the knee. But what we are dealing essentially a congenital dislocation where patella is permanently and irreducible and fixed on the lateral aspect of the femoral condyle. On clinical examination also, habitual essentially is a mobile patella, you can reduce it, while a congenital patella essentially is a fixed and immobile patella. Other features also which were actually corroborating with the congenital patella is a fixed flexion deformity, so she's walking with a flexion knee. There is a bit of scienu valgum, that's around 5 to 7 degrees, not too much. The foot deformity was not essentially there. The tibial torsion was there, slightly on the higher side, but still in the normal range. But these patients with the habitual patellar dislocations don't have any flexion contractures. Both of these essentially have some amount of other deformities, which we're not going to talk about it. So essentially the diagnosis is fitting more into congenital dislocation rather than a habitual dislocation of the patella. So this is the CT pictures, we already talked about it. Again, an audience response so that we can generate some discussions. If you get this patient at 18 years of age, what essentially would be your treatment protocol in this? Are you going to do a lateral release with a TTO? Are you going to do an MPFL release with the lateral release with a TTO? Or some amount of trochleoplasty plus minus TTO? Or a medial imbrication, lateral lengthening and a TTO? So we see the audience response mainly going in favor of an MPFL reconstruction, a lateral retinacular release and a TTO. Okay, that's fair enough. So let's just show you the dissection pictures. So we opened up the knee. That's the patella actually sitting out. The patellar tendon is actually going all the way here on the medial side. The lateral surface, there is hardly any, it's all scarred here on the lateral side. That's the vastus lateralis. This is not working here. In such cases, I think the basic concept about you talking about a lateral release makes sense. The problem about lateral release essentially is when you do a lateral release and try to put the patella back into the normal position. So when you do a lateral release in these patients which have been congenitally dislocated, and when you try to put them back into the trochlear groove, you actually end up leaving a large lateral gap which cannot be actually fulfilled. So in such cases, I agree that yes, doing a realignment here would be helpful. नहीं चल दूसरा दे दो. Realignment would be good idea because you would actually need to do a distal realignment. But I think strategically landing the structures on the lateral side and just releasing these structures would actually open it up and do a large amount of gap where synovial herniation would happen. And when you do a lateral release like this, it will be an extensile lateral release. You actually weaken your extensor mechanism and patient's extension would not be good. So there are articles where you essentially do in these cases what is called as a Z-plasty or a lateral structures lengthening by Z-plasty. So if you look into the lateral structures on this side, our lateral structures have got superficial oblique layer and a deep transverse layer. And you will essentially need to dissect. You essentially need to dissect between the superficial oblique layers, go down, and then do a transverse cut in the deep transverse layer, so that you do something like a coronal Z-plasty, and you can lengthen the lateral structures rather than doing a lateral release. That would give you a very good cover on the lateral side as well. So that's essentially what you start doing it. You first essentially release the vastus lateralis because the whole alignment is going lateral. You also do a bit of iliotibial release because these patients are actually walking with a tibial torsion and there is a flexion deformity. And you release the medial tibial patellofemoral ligament and now start to work onto the lateral structures here. As I said, and add on a tibial tubercle osteotomy also. So you look into this TTO. This is the area where we actually did an oblique tibial tubercle osteotomy. And we are going to anteriorize and medialize this so that you actually gain up flexion also. There is a bit amount of trochlear dysplasia, not so much. Lower part, the groove is okay. Obviously, the compression has caused some compression on this side. You're not going to operate on that. That's how the tibial tubercle osteotomy, which was actually done. The whole part of this bone has been lifted up. We have anteriorized it and medialized it and fixed here. And this is sitting now nicely and congruent. Now these structures have to be lengthened. And essentially you do a lengthened, as I told you, is a Z-plasty kind of procedure where you're going to release from the superficial and the deep part. And you get a very nice layer on this side to cover this whole area. So you get a nice layer of the tissue which you can cover nicely. So this is the preoperative, the scarred area. That's in a flexion. So you won't be able to do that kind of amount of flexion. That's realigned patella. And that whole part can now be easily closed nicely without any possibility of a synovial herniation or a extensor mechanism problem in future. On the medial side, we actually end up doing more of a medial. That's a complete release on the lateral side. That's a complete closure of the lateral side. We released a bit of quadriceps here because we wanted to lengthen the quadriceps. So VMO was released and at flexion we stitched it back here. So see the closure here and the closure down, and then we were able to close it all the way here with the tissue. On the medial side also, we did some amount of VMO medialization because when the patella is dislocated out for pretty long time, a congenital patellar dislocation, and patient is 18 years of age, this all things are stretched out. So in these cases, we actually stitched the VMO as well as capsule and medial imbrication and stitched it onto the patella. So the whole procedure essentially involved all of these things which we did. It was essentially a lateral patellar retinaculum Z-plasty, a tibial tubercle osteotomy where we are going to do anteriorization and medialization, and a medial plication, which essentially means VMO advancement as well as medial capsular plication. That's a post-operative regime which we followed. The post-operative flexion was restricted for around 4 weeks to around 30 degrees or so, and slowly flexion and weight bearing was enhanced. That's a picture of a follow-up. The knee is flexing nicely around 110 degrees or so, extending nicely, and patella, which was always dislocated here, is sitting nicely into the groove, and patient is quite satisfied. So let's have discussion on this case. I end my case here.
Would you do a tibial tuberosity in 12-year-olds also?
Tibial tuberosity?
Tibial tuberosity medialization.
Yeah, we did, sir.
In 12 years old, as you were saying.
So then we actually change into a soft tissue procedure.
Yes.
We don't do any bony procedure, so we can do a patellar tendon rerouting, and yeah, we do a distal realignment, but not a bony procedure in a 12-year-old.
Sir, You have not done MPFL reconstruction
No.
in this case. Any reason behind that?
Usually I don't think so. You see, these patellars are very small and hypoplastic. I don't want to drill holes into the patella, number one. Number two, I think the pathology is essentially not only the MPFL. The whole medial structure and the sleeve has been stretched out congenitally, which is very wide. So just putting a small graft there probably might not work. So if at all you're doing, you have to actually advance the medial VMO and also do a medial capsular imbrication. That's a complete procedure.
And at the same time, you can also add MPFL to that.
I mean, once you have done that,
Yeah.
and your knee is stable on table,
Yeah.
MPFL is just a plus minus.
One more thing, with such a release on the lateral side with this jet plasty,
Yeah.
most of the time you will have wound problem in post-op period. So do you counsel this to the patient? Because in my cases, almost more than 50% is having some kind of little bit of wound dehiscence in such type of this lateral
we
lesion.
didn't see any wound dehiscence in
But
this
in
case.
this case, again, there was very big scar and all this.
Yeah, definitely. I mean, if you, can you just put up the presentation? Yeah. So if you look here at this picture here, we have actually raised a nice thick flap of the lateral side. And what you are talking about, possibly necrosis in this area, you are talking about?
No, skin necrosis. Skin
I think this
necrosis
is a
and-
large full thickness flap here. You are right, possibly somewhere here the skin might be thin. But
So I have started doing
you can
this
counsel it, but-
counseling about that.
yeah, sorry.
I have started doing counseling about that
Oh, yeah.
because it's almost more than 50% of the cases there is some wound problem for the skin.
No, she healed actually well, so we don't have this. But I think you are right. There is some scarring which is bad here, but essentially the
Rest is fine.
is okay. Yeah, Gaurav.
Difficult ones, these will never become 100% happy no
Absolutely.
matter what the best you do.
Absolutely.
You spoke about 4-degree valgus. You got an orthoscanogram to have a look at
No, I
it?
don't have it here. We have the CTs. I was unable to retrieve it.
Achha, because the X-ray, can we go back to the X-ray?
We will go
X-ray
back to
looked a
X-ray.
bit more.
No, I'll just
So
go
I
to
thought-
CT. So that's the CT picture. I'll go back to X-ray.
Plain ek X-ray tha na?
Yeah.
This one, huh? I mean, just a thought, if it was more, you could have corrected the valgus and that would have helped you, get the alignment back.
Again, as we were talking in the previous case, all of these cases have something which is borderline. And when you are operating on a case where you are actually doing a tibial tubercle osteotomy, a lot of soft tissue releases, medial imbrications, you are still quite not sure whether you are actually going to do a quadriceplasty also and a distal femoral osteotomy also. So, yeah.
Yeah. So,
But I think that's a good idea. But possibly,
DFO karke valgus correction.
so it's
That would
essentially
help
not
you
a
with the bony
dynamic.
realignment.
Yeah, Gaurav, it's actually not a dynamic instability where possibly a valgus is actually contributing to it. It's a fixed patellar dislocation. It might, these girls often have valgus. So they often have valgus.
Pretty much, always, yeah.
And I think we go back to the first one. And if you see her walking here, so possibly you would be
She is
able to see.
intoeing. If you look at her gait, she's constantly intoeing
Yeah,
in an
because
attempt
she's
to
painful
contain.
and she keeps the knee into a
Yeah.
flexion when she's walking. She's
Fixed
guarding it.
flexion and intoeing will always be there to, in an attempt to,
To,
get
to
the extensor mechanism to realign.
Yeah, absolutely, to realign. But
That's what
again,
it
when
is.
we
See
said
that
about it,
intoing.
because the extensor mechanism is not working in the same direction,
Huh.
so these are compensatory mechanisms.
Huh.
These are compensatory mechanisms. So if I possibly, maybe in future meeting, if I can get a walking video, because all the video which I was getting is sitting video, her gait patterns has improved dramatically. She's able to walk nicely, her knee extensions are back, and her range of movement is around 110 degrees, I think, which is quite good enough for us to understand. And it's not looking so bad as I was.
no,
No, it looks fine.
this case has been well handled by the technique which he has shown. But at the other end of the spectrum, we do see patients coming to us at 50 years, 60 years with congenital dislocation of the patella. They had no limping or nothing, but they come to us with osteoarthritic knee, which is an expected thing at that age. For 60 years, they never came for a patella which remained dislocated. This patient came early, so probably this has been handled the way it needed to be handled. But a good percentage of patients will present to you all of a sudden at 60 years and you find that the patella is dislocated. That's
So bottom
also-
line essentially is you don't do a lateral release in these cases. you essentially would go ahead and do a lateral Z-plasty or a lengthening procedure, a coronal plane one.
So my question is continuation to sir's question. If this patient presented to you at 30, 35 with the same scenario, so with some arthritis at patellofemoral joint, what will be your line of
So I don't think so.
management?
Then reconstructive surgeries are going to help. Then you actually end up making patient worse by trying to put in the patella the position. I think that was the point which was rightly said. At 35, when there is no cartilage which is left on the patella, the trochlear groove is essentially more or less flat. You put the patella back, she becomes much more painful.
Thank you, sir.